Welcome to the Northeast Georgia Medical Center GME Annual Research and Quality Improvement Symposium keynote presentation. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenters, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section, and we'll be sure to ask that for you. A link to the event survey will be shared at the end of the program. It is now my pleasure to introduce Shane Robinson, GME Research and Quality Improvement Director.
All right, thank you. It is my pleasure to announce and address our keynote speaker. So Dr. Egolum serves as the LVAD Program Director and the Program Director for the Cardiology Fellowship Program. He received his medical degree from Howard University College of Medicine. He then completed his residency in internal medicine and fellowships in general cardiology and advanced heart failure and transplant cardiology from Vanderbilt University Medical Center. He also served as chief fellow during his training at Vanderbilt. Dr. Egolum is a board certified in advanced heart failure, transplant cardiology, internal medicine, and cardiovascular disease. He has been honored with numerous awards for his scholarship, including clinical practice, teaching, and research. He has contributed to or has been a lead author for more than 50 original research articles, book chapters, abstracts, and peer-reviewed publications, which was presented at national and international society meetings. Additionally, Dr. Egolum has expertise and a specific interest in the care and management of patients with cardiac amyloidosis, pulmonary arterial hypertension, and cardiac sarcoidosis. He previously served as the inaugural director of the Heart Failure Treatment and Recovery Center at NGMC, overseeing the modernization of the section and bringing in multiple new heart failure therapeutics. He has held other leadership roles at NGMC, including Chief of Cardiology, Physician Executive on the JOC Group Governing Board, and Physician Lead for the GHI Quality. He is the inaugural recipient of the Chuck and Debbie Jones Endowed Professor of Cardiology and Medical Education. Please join me in welcoming Dr. Egolum.
All right, good afternoon. Thanks for that wonderful introduction, really appreciate it. I was kind of joking earlier, I'm happy I'm giving this talk, right as you guys have already started having lunch and not before, right? Because you never want to be the person that stands between people and food, so I'm happy on that regard. I think as, and you guys may be seated, as I give this presentation, certainly you'll see me up here and there's going to be a lot of things that I talk about, the papers we've published and the work we've done, but even though I'm standing here, there's no way I could have done this without almost everyone in this room, and specifically our research staff. I know a lot of the work they do sometimes is not necessarily obvious in front of everyone, but there's sort of that quiet but powerful army that really helps us get a lot of stuff done. So I want to make sure we acknowledge that up front. Having stated that, my talk today is going to focus on how do we leverage research and quality improvement to really develop high functioning or high quality service lines. So these are my disclosures. I wanted to start first by level setting all of us. I think we all know what our mission statement is, and that is around the topic of improving the health of our community in all we do. I think if we keep that in mind, then it becomes clearly obvious why research has to be part of what we do in taking care of our patients. We'll briefly go through the outline of today's presentation. I'll review current healthcare challenges, doing an overview of the impact of research and QI, so I'll point out what I think the highlights are. And then I'll go into specific research, clinical trials, stuff we've done and published, and really demonstrate what that impact has been for our health system. I also wanted to touch on what impact this training, residency, fellowship has from a research perspective, and Dr. Riaz Mahmoud is here, and I'll have him kind of speak to that aspect of things. And then I'll briefly review what I feel as though would be our future directions and what our next steps should be to really keep elevating our game as we go forward in this regard. So what are the challenges that we face in today's healthcare industry and system? The number one thing that we constantly hear about is the cost of care. One thing that's pretty clear is that in the United States, the cost of medical care keeps skyrocketing, as we can see as time has gone on and progressed. But the problem we have is that there's not much increased outcomes as we compare ourselves to other developed nations. So the question is, why do we spend more, but we don't have as good outcomes as other countries do? The other part of it that we've got to keep in mind, we're having an increase in percentage of patients who are above the age of 65. It's well known and documented that for elderly patients, and as time goes on, there's more and more medical issues that come about. Patients are living longer. Their care becomes much more complicated and much more expensive. So that is something we do have to grapple with. Combining that with the current pressure on trying to bring costs down, so there's a lot of push for value-based care and finding ways that we can provide effective care for patients and it not be so expensive. The other thing I think that plays well as we look at a health system that's really going to be high functioning and have effective service lines is how quickly technology, medical therapy, and all these things are evolving extremely quickly. So if we look back, say, 25 years ago, back towards the end of the World War II, usually knowledge doubled every 25 years. There's pretty clear data now that in the current era that we're in, our human knowledge doubles roughly every 13 months. If we break that down and we focus specifically on knowledge related to medical care, roughly every 18 months, the information we have doubles. So no longer are we simply sitting by and it takes 5, 10, 15 years and we'll know something different. With AI and multiple technologies in places, we are quickly learning and adopting a lot of information. So any health system that's going to be high functioning and excellent service lines has to have a way to account for this and really incorporate it in the practice of medicine and taking care of patients. The other thing I'll touch on is this whole pathway, new drug and medical device pathway to approval. When we look at the data, it takes roughly anywhere from 10 to 15 years for a device, medication, to be thought about, researched, developed, and finally to approval. If there's one reason why I do research, it's because of this. The idea that I could be seeing a patient in clinic today, and there's some therapy option that's being studied somewhere else that could help them today, and not being able to have access to that is something I think really drives me to want to do research, because again, we can provide tomorrow's care today. So I think this is something we need to keep in mind as we really think about how we want to be as a health system and how we want to develop and move forward. And again, research helps to address this aspect of things. So as we talk through this, I wanted to discuss, what exactly are the features of a high-quality service line before we delve into what exactly, how research engages with that. I think number one, above and beyond, has to be safety. We want patients to come to our health system, be appropriately cared for, go home, be alive without any undue harm. We know that medical harm is one of the leading causes of deaths of patients. So safety is number one. Timely. If someone arrives to the ER with a heart attack, we need to move them quickly to the cath lab. And if they need a stent, they need to get it appropriately. The care we provide must be evidence-based, right? The days of, this is how I did it, or this is what I think works, we're way past that. There's evidence that should be supported in whatever care modalities we provide for patients. We have to be efficient, right? We need to manage and reduce waste, whether that's financial, whether it's the use of human resources, staff. We need to focus our teams on what appropriate care delivery will make a difference for patient care. Equity is a buzzword, but in reality, it's something we need to address. If we're going to be high functioning, we need to ensure that Mr. Jones, Mrs. Jones, Tom, Dick, Harry, whoever it is, when they come in, they all get the same level of care related to the disease pathology that they have present. Regardless of what we do, whatever we provide and how we care for patients, the patients need to be at the center of it. We need to have conversations with them, make them feel comfortable that we're taking care of them as our care team. They need to feel as though we respect whatever cultural nuances they may have, what their views are on their care. Barring that, we don't have health care because the patient needs to be at the center. All right, so what is the impact of research and quality improvement? And again, we will demonstrate this with clinical trials that I'll discuss shortly. But I think for one, there's direct impact that it has on the care of the patient. Number one, if we identify early therapeutic options, things that can be intervened on, whether we study a new drug, a new device therapy, Or we have device therapies present, but we use quality improvement to ensure that we're appropriately utilizing and providing that for patients. We will see a decrease in mortality and/or morbidity. Lower complications, right? If we have good quality systems in place, we catch errors and we find ways to PD the process and ensure that this does not happen again. When patients are appropriately cared for, with some of the support from research and QI, their patient experience is much better. The patient has a much better sense of the experience they're having, they feel engaged with their care, and their patient experience is highly improved. Financial impact. I talked earlier about the cost of healthcare. This is a big topic. This is a constant discussion. Appropriately utilizing research and QI, we can reduce a lot of waste. Implementing therapies that can reduce readmissions and penalties, right? Those are things that go to the bottom line of the health system and also helps to support the mission. We've talked about value-based care, being able to have these modalities where research companies or sponsors are paying for studies and drug therapy and things of that nature. Does provide some cost saving for the system, and as a result makes the system financially more buoyant. And certainly as we leverage research, perhaps those finance folks, they can maybe be able to get preferred financing for some of the products that we want to bring here. If you've been involved in research, engaged with the sponsors, you're more able to do that and really improve the finances of the health system. The operational impact, right? We want to standardize care. QI does that really well, right? We find what the standards are, we look through the process, when are we not meeting it, and then we can use those processes to identify and implement those changes. Efficient workflows, right? So again, I use the analogy of a patient having a STEMI in the ER. There's a pattern and a workflow that a patient has to go through along with supportive staff so they can be appropriately taken care of. And again, reducing variability. This is where a lot of outcomes vary, where patients do not get standard therapies related to the medical issues that they have. Beyond that, I think there's a cultural impact. When research and QI is embedded in the very fabric of any health system, it embeds a culture of excellence, right? If we make this part of what we do and everyone knows we review our processes, we look to improve, then evidence-based medicine becomes part of what we do. It's not a guesswork or if and when we're ready for it. I think the other component is innovation, right? There's many medical questions we're yet to answer, right? Patients come in with disease pathologies that are maybe relatively rare or a complication of a specific known therapy. And we sometimes as physicians, clinicians have to think outside the box and come up with ways that we can address these issues. So I think having an environment where research and QI is part of it, it makes you think outside the box to really deliver care that may not have been readily available or known about prior to this. Reputation, as we want to grow the health system and better be recognized for the things we do here, and we do a lot of quite wonderful things, it grows our reputation locally, regionally, nationally as the work we do gets put out there. Career development for staff, in whatever regard, whether in the regulatory sense, our research coordinators, directors, this is an opportunity for that to happen. And for our faculty, I've certainly been a beneficiary of this as a lot of my career growth has been related to research and publications and again, things out there. Residents and fellows, yeah, they come with us, they come here, they train. Eventually, some graduate and leave. But I guarantee you, some of the connections they've made here, some of the research interests they've developed and been part of is what spawns their future career. So the bottom line is research and quality improvement drives excellence. It's essential for any modern healthcare system. And in reality it's a non-negotiable. Now I'll delve into Northeast Georgia Medical Center, Northeast Georgia Health System, and really look at some specific areas of how research has had an impact on what we do. A lot of the work we've done in this space has actually positioned NGHS as a leader, that we're offering high quality, innovative, and cutting-edge care for patients. It's a big part of recruitment. I know when I get on the meetings and we're recruiting fellows, this is something that we speak about all the time. This is part of how we've recruited residents, fellows, because they see the research, the QI, and they want to be engaged and be part of it. Provide access to our patients, right? So when we have novel therapeutic options, we want to be able to have that for our patients in our community so they don't have to travel out of there. Looking at the finances, right? So it does generate revenue, right? So this not to overemphasize finances, but these are the questions we get asked when we try to bring in more research. What's the financial impact? And certainly the finances, when the organization is healthy and financially buoyant, it does support the mission, so there's a component of that. Support staff and physician engagement, right? So the physicians that are working here, the nurses, nurse practitioners, those who do this sort of work, this is what part of their motivation is. They come to work every day, they want to be engaged because they see the intention, the benefits of doing this. Patient retention, right? There's several patients we've had who've not had to leave the health system to go seek care at other places because we have a clinical trial that may benefit them that other places don't have. We've had patients call and reach out. Hey, I saw you guys were a part of this clinical trial. The hospital I'm being treated at does not have access to this. Could I come here, become your all's patient, and be part of the process? Having stated that, again, why does all this matter? So I think research and QI drives better outcomes. The education we provide sustains excellence, particularly in the context of GME. And I think when you bring both together, we have institutional growth. The one thing I'll mention is oftentimes research, quality improvement is looked at as, well, that's extra work. Why do you have to do this? You could just come see patients and go home. Well, I'll put it to you, it's not extra work, it is the work, right? This is the work we're here to do because, again, it's going to improve the care of our patients in our community. What I'm going to dive into now is just go over some of the clinical trial work we've done and the direct impact it has had in our health system by view of an example. So I will say, mark my word, today is April 22nd at 12:18 p.m. I think this device is going to revolutionize how we manage heart failure going forward. So this is a Reprieve Cardiovascular system. It's part of the clinical trial called a FASTER trial. For heart failure patients, when they come in decompensated, on average, they stay in the hospital roughly 7 days plus to get volume off. When we're managing these patients, we're oftentimes, educated guesses as to what diuretic doses would work appropriately for these patients. This FASTER system, part of the Reprieve Cardiovascular system, what it involves is a console, as you see there. There's a Foley that's inserted in the patient. There's a diuretic infusion that's given through the console, and it measures the patient's urinary sodium, and it titrates the diuretic to get adequate volume removal. So it can personalize the dose the patient needs to receive. Additionally, it monitors the patient's volume status, fluid removal, and at specific times, it may give normal saline back to the patient in an effort to preserve renal function, right? That's one of the complications we have. We try to get volume off. Patients develop renal dysfunction, the length of stay is much longer. So again, this addresses a bunch of things that we have problems with. Number one, appropriately identifying dose for patients, removing volume very quickly. Now you might ask, well, how quickly does that happen? This is a publication our research team put out on our listserv. So this was our first patient that we enrolled. There's a picture with myself, our PA, our nurses, and our research nurse team. And you can see the console there. So in red is the feedback the patient gave. The patient experienced rapid decongestion within 48 hours, felt significantly better, and maintained stable kidney function. He was very pleased with the results. So this was a gentleman with recurrent heart failure. He oftentimes comes in with 30, 40 pounds of fluid. He stays in the hospital a week and a half. And within just under 36 hours, we were able to get 30 pounds of fluid off of him, maintain his renal function, so much so that in the next day, he was pretty much ready to go home. So imagine if we're able to apply this throughout the health system. We do roughly 1,200 heart failure admissions a year. Let's say we deploy this technology in half those patients, 600 patients, and we can take their length of stay from 7 days on average to 1 day. What do? We get patients out of the hospital earlier. Most patients don't want to be here that long, right? They get decongested much more quickly. The cost of care goes down because now we're saving 6 hospital days. And if you multiply that by 600 plus patients, there's millions of dollars that can be saved. The additional part of this is when patients are appropriately decongested, they're less likely to come back into the hospital. So again, this is an ongoing clinical study, and we'll see the impact it has on that. But I do believe this could change how we manage patients. And again, the fact that we're part of this clinical trial, that means we have the device here. And the patients are benefiting today, not 15 years from now, when it's approved and out for use. Our residents, fellows who are part of the team, they're learning about what this device is. Well, our nursing team got trained on it, our Wood Stewart nurses. So if this is approved, then it becomes part of what we do. Well, guess what? We don't have as much of a lift. We already have the technology here, and we're able to implement it quickly. Financially, there will be a benefit to the system, not only from reduced readmissions, but if already having a workflow for this, we can implement it quickly, and you're in a position where you can negotiate and, with a company that makes the device. So again, just mark my word, this will revolutionize how we manage heart failure. The other study I wanted to talk about, and I'll go in detail, is the RELIEVE heart failure study. For patients that have heart failure, whether it's heart failure with preserved EF, heart failure reduced EF, they oftentimes have symptoms when they exert themselves. So one of the things we've known is that when a heart failure patient exerts himself, their intracardiac pressure becomes elevated, and that process of the pressures getting elevated in the heart may lead to pulmonary edema, fluid buildup, and makes him short of breath. This device is the V-Wave device, and it's a conditional shunt device that was designed. And the purpose of this device is that it would be placed in the top chambers of the heart between the atria, and whenever a patient exerted themselves and those pressures elevated, it would open and shunt blood towards the right side of the heart and relieve that pressure, and ideally, hopefully help the patient feel much better. So this was a clinical trial we were involved in a few years ago, and I'll show you what impact they had in one of our patients. So this patient got enrolled and had the device placed. So these are his words. This clinical trial has drastically improved my quality of life. For years, I basically lived in the hospital, and he wasn't lying. He was basically always in the hospital. Unable to breathe on my own, walk outside, or drive a car. Thanks to my care team, I'm able to live a better life. This gentleman was in the hospital literally every other week. He's had every test known to man. We could not specifically find an etiology for his symptoms. He was not having much of a quality of life, but we looked and we saw that he qualified for this therapeutic option, right? He went through the protocol, got randomized, had the device placed, and now he's doing great. He's living his life. So really a major change for him. Keep in mind, this device is not yet approved. It's still going through the regulatory process and further studies. So this device may not be approved for use for another 10 to 15 years. But again, we've been able to help him today, not waiting 10, 15 years down the line. And additionally, as we talk about reputational growth for our health system, you can see on the bottom, there's an article we ended up publishing in Circulation, which is a major cardiology journal, get this information out there about the therapeutic benefit of this device. So again, another excellent idea of how research impacts patients immediately. I'll also pivot to cardiac amyloidosis. I spent a fair amount of my clinical time and expertise within this space. So cardiac amyloidosis, in a nutshell, is a disease process where proteins in the body misfold and deposit in the heart, thicken the heart muscle, and over time, patients develop heart failure, heart arrhythmias, and becomes extremely sick. They can have neuropathy, weight loss, kidney problems. When undiagnosed, these patients don't live very long, probably 3-4 years. They live very miserable lives. They're in and out of the hospital. They're very costly to the system because they're not oftentimes diagnosed appropriately. So since during my training time, I did spend a good of my training within an amyloid clinic. And back then, 2016, 2017, there was no treatment options available for cardiac amyloid. The only patients where I trained that had access to stuff they were in a clinical trial, right? So you can see the difference on how patients did when they were part of a clinical trial and got treated appropriately. Subsequently, I came to Northeast Georgia Medical Center, and at that time, no one was really looking for amyloid, but I came in, saw many patients there had cardiac amyloidosis. So I looked at how they were doing compared to patients where I came from that had clinical trials and were part of the process. Vast difference. A lot of patients were extremely sick and essentially on death's door. So seeing that need, we've participated in a lot of clinical trials. You can see multiple of the publications that have been listed here. As we talk about QI, Dr. Riaz Mahmood, along with some of his co-fellows, have done work, looking at our electronic medical records and trying to find ways to identify these persons a little earlier. We do some outreach programs, provide educations for patients, families, and other physicians, so they can gradually look for this disease process. From the work we've done and multiple clinical trials that we've been part of, we've had national publications. You can see towards the bottom there the patisiran, which is a drug for amyloidosis management and impact it had on neuropathy. A newer drug, this drug just got approved officially in November of 2025 for commercial use for treatment of cardiac amyloidosis. But by view of being part of a clinical trial several years ago, several of our patients were able to get in the study and have access to this drug. And now it's been approved in the last 6 or so months for management of patients. Additionally, some more work we did with patisiran to look at that. So part of my career growth has been really around this amyloid, right? We've been able to do these clinical trials, the multiple publications. It's given me opportunities to sit on national guideline writing committees. I get invited a fair bit to talk about amyloidosis. This was a poster set up from the AHA where I was one of the panelists talking about cardiac amyloidosis. So again, the research has really helped with growth and evolvement of my own career, and others that have been involved with it too as well. This is a local symposium that's upcoming in Atlanta, and we will be part of that as well. So if folks are interested, you can learn more about cardiac amyloidosis in that regard. Having stated that, I think the ecosystem we've built around cardiac amyloidosis, the clinical trials, quality improvement work that's been done, myself with the fellows, the publications, it really puts us on the radar. So when companies are looking for places where they can go and have clinical trials done in cardiac amyloidosis, they oftentimes reach out to our program because we have the patient population and the network that's set up to look at us. One such study that we're in the process of onboarding that really came from all this work we've done is a study called the AWARE clinical trial. This is an AI-enhanced echocardiography workflow to advance recognition and diagnosis of cardiac amyloidosis. As I alluded to earlier, a lot of these patients are either misdiagnosed or not diagnosed at all. Certainly, we're happy to see all patients in the heart failure clinic and decide if they have cardiac amyloidosis, but that's just not practical. When I look at the data in our system, I believe we probably have close to 6,000 patients that have cardiac amyloidosis that are yet identified. So far, I think in our group, we're treating close to about 200 patients. So we've not even scratched the surface. So what are ways that we can actually proactively find these patients and then route them to our specialty so they can be appropriately evaluated and managed accordingly? So this is the VIS Cardiac Amyloidosis Solution System. What it is an AI-empowered echo review product. So when echocardiograms are done, it reviews for signs of cardiac amyloidosis, but it goes just beyond that. Not only does it look at the echo, it's able to search our EMR and pull in data, what's the patient's NT-proBNP, how often have they been in the hospital, do they have AFib? And in doing that, it creates an algorithm of the likelihood that a patient has cardiac amyloidosis. And then this feeds into a workflow registry or a panel, if you will, and then we can specifically review that patient. And if we have high enough suspicion, we'll have someone call them and say, look, we've reviewed your records, we think you may have this problem, we would like for you to come in and see us, right? So no longer are we simply just waiting for a patient to get sick and land in our laps. We're being proactive to engage these patients. So you can see a little cutout there that says, new patient with suspected cardiac amyloidosis detected, and you can pull it up that way. So again, what other impact does this have? From a clinician's perspective, having an automated system that can detect cardiac amyloidosis is a big win, a big lift. No matter how hard we try, there's no way I can review every single of the 50,000 plus echoes that get done yearly in our institution. Chart summarization and guideline-based recommendation, right? So making sure we're following the pathway, making sure patients are being appropriately evaluated and coming up with an appropriate diagnosis. And then seamless care coordination, right? So now we create a suspect, we detect, and we're reaching out to the patient and bringing them in accordingly. What impact does this have for the hospital system? We go back to quality improvement. If patients have been misdiagnosed or underdiagnosed, they have worse outcomes because we've not found the appropriate disease process and we're not treating them appropriately. So that changes the game. Now we can more appropriately, hopefully make earlier diagnosis and impact the outcomes for the patients. There's clear near-term economics, right? So this doesn't involve hiring new staff. It's really utilizing resources we already have in place to make this work. And then enterprise workflow lift, right? It elevates what we do here. This is going to be novel and not something that's widely implemented. I'll tell you, this institution or organization sponsoring the study, they wanted 5 institutions involved. So, you know, we're going to be one of the 5. I can tell you the other 4 are major, large academic centers. So we're the only large community hospital that's going to be involved in this process to really be part of it. So additional institutional impact, again, this early access to innovative cardiology workflow technology, right? So we'll be one of the first 5 to have this. We work closely with them, and we can, as we see things fit and how it's working, we can tweak this. So we can actually modify the product for it to be extremely well organized and dedicated to how we want to utilize it. And then additional, there's opportunities for co-authorship for residents, fellows, and physicians. So again, that reputational component continues to develop from that aspect of things. So again, I think those 3 studies that we've looked at shows the immediate impact and clinical benefit of clinical research. So the other thing I'll touch on, you know, as you do research or you're involved and you're publishing your guidelines, you go out, you talk to colleagues, it changes the way you think about patient care. It makes you ask the question, okay, this is a therapy we have for this disease, but it's not improving patient outcome. What else can we do? Or again, you may have a rare complication of a known device therapy that no one else has managed. But if you're in the research space and you're used to thinking through these things, you can come up with novel solutions. So I'll go through a few examples where, you know, being in this sort of role and being in this world has really impacted how we've cared for patients above and beyond clinical trials and things of that nature. So this was a case that was published in JACC, one of our major cardiology journals. So it's a patient that had pulmonary hypertension, so elevated pressures in the lungs. But their pulmonary hypertension was related to what we call CTEPH, so chronic thromboembolic pulmonary hypertension, meaning these patients have had recurrent episodes of clots in the lungs, and that has damaged the arteries in the lungs and elevated the pressure. So he came in, this patient was extremely sick. He was on death's door. Naturally, one of the ways we take care of these folks is to put them on ECMO, right? So a large pump system that can support him. But he was very debilitated, malnourished. There was just no way he was a candidate for it. So really the option was imminent death. So at that point, you know, I talked to one of my colleagues, Ronnie Ramadan, and I was like, okay, well, what else can we do? There's no literature that tells us what to do in this situation. No one's published on this topic. So we actually went ahead and we did what we call an atrial septostomy. So we put a tiny hole in the top chamber of the heart. The key here is that with the right ventricle failing, you're not getting adequate blood flow to the left, and so there's just not much blood flow anywhere. So by putting a hole through the atrial septum, we had blood that could not go through the pulmonary arteries to the left side. Now that blood could shunt through the atria. So again, he was very hypoxic, but he was getting blood flow. So in any case, the gentleman tolerated it. He had blood flow, he survived. We ended up getting him to a local institution where he underwent pulmonary endarterectomy, and he's still alive today, living his life. So again, that's a patient that there's no textbook that you could have read to answer that question. The other thing I'll talk about is this VAD-wean registry. Forgive my quick photo there. That's a little bit off kilter. But when we think about the goals and roles in heart failure therapy, when someone has advanced heart failure therapy, there's really 2 therapeutic options that we consider. One is heart transplant, and the other is an LVAD, a mechanical support device. Generally, when a mechanical support device like an LVAD, a HeartMate 3 is placed, those patients have those pumps either for the rest of their life, or they have the pump in until they get a heart transplant. What we're suggesting, and a fair amount of my work as a fellow was around this topic, is that there's a potential third pathway, where we could put the pump in, support the patient's heart, give them more medical therapy, recover their heart function, and eventually remove the LVAD or omit the LVAD in some sense. And then that patient goes on, perhaps they stay on medical therapy, but they don't need a transplant, they don't have to worry about LVAD anymore, and things of that nature. So that's what's called the VAD-WEAN protocol. You can see there's multiple centers nationwide, predominantly in the East Coast, throughout Europe, Japan, and all those other places that are involved. So we're working through this, and we'll likely be the first center in Georgia that actually is doing this work for patients. So think about the impact of this. Someone who's 25 years old comes in, you put an LVAD in, and in a year or two, their heart function recovers, and you can take the LVAD out, and that patient continues to live a great life. All right, another one I'll talk about is this. This is related to the LVAD therapy. So the LVAD pump goes into the apex of the heart towards the bottom. It pulls blood out, puts it through the graft, and then delivers it to the rest of the body. As you can imagine, at times you may form a clot. So one of our patients came in, he had a clot in the graft that brings the blood out. And if you're not bringing adequate blood, those patients are in extremis, they're not doing well, and they can die if we don't intervene. Naturally, one of the options would be to go to surgery, right? Open the chest up, our surgeon would change the device, but that's a major surgery, and there's a chance a patient may not make it off the table, particularly if they're critically ill. So again, this happened on I think late Sunday, and patient came in crashing. Tasia, one of our fellows, was able to write this case up. But again, collaboration between myself, Dr. Ramadan, our structural interventionalist, we came up with a plan. All right, patient went to the cath lab. We used specialized catheters, and we were able to clear out the clot. And additionally, as part of doing this, small basket-shaped devices were placed in the carotid artery, because naturally, if we're trying to move clots, we can embolize and cause a stroke. So he put those up, quickly removed all the clot, everything cleared up, the patient's pump was working well, and he was doing great. So this is one of the first cases that's been published that actually outlines this as an approach. And we did that here at Northeast Georgia. And again, I'll tell you, the only way we were able to do this is because we've been involved in the research and publications and to know what things are happening and using the knowledge and that acumen to really apply to novel situations. And the patient has excellent outcome because of it. The other thing I'll touch on that we've been able to do here, and this was a first in human, not just first in Georgia or US, but as far as we can tell, first in the world. When patients have ventricular assist devices, they're prone to arrhythmias. Anyone with sick heart can have ventricular tachycardia. These are serious rhythm issues. So we had a patient who had an LVAD, and he continuously had recurrent arrhythmias despite all our best efforts. And we wanted to ablate or get rid of that arrhythmia. There's several ways arrhythmia ablations can be done. Traditionally, it's been done with cold or heat, but that generally causes a lot of tissue damage and there's a lot of complications for it. The newer version of doing ablations now is what we call PFA, pulse field ablation, where high electrical impulses are used to damage the tissue that's leading to ventricular tachycardia and perhaps preventing it. The concern here was that, well, you're using a device that's putting out a lot of electrical signals. Are we going to damage the pump? Well, if we damage the pump, I mean, that may almost mean certain death for the patient. But we talked through it. We talked as a team. We looked through the literature, reviewed, and no one else has really done much of it, maybe one place or so, but no one's published on it. But from what we could tell, there's really no reason why we couldn't do this. It was just that it's never really been done. But again, being aware of the data, being in the space, we were successfully Dr. Chandra was able to ablate this patient's arrhythmia. Again, this was published in one of our national journals. So now patients beyond our institution, other places can benefit from having this done, as it's a much more effective way of doing ablations. The other thing we've looked at, in our clinic, we ask patients to weigh themselves daily as heart failure patients. If your weight goes up, we want you to take diuretics, et cetera, et cetera. But one of the questions we asked, well, what if, as patients step on their scale, what if we could get more information? Something that's actionable for the clinical team, but also for the patient. This was the genesis of the SCALE HF trial. So this is a special scale that patients stand on. It sends an electrical signal through the body, comes back down, and through specialized measurements, it could determine what's the patient's fluid status. Are they volume overloaded? They gained 2 pounds. Well, how much of that 2 pounds was fluid weight gain versus other things? It can give you an estimate of what the patient's heart output is, how well is the heart pumping. And additionally, it could estimate what your blood pressure is. So as a result of that, we believed in this technology. We were part of the SCALE HF trial. So several of our patients had this device, and we were able to use it clinically to take care of them. Again, this device is still not approved, it's still going through additional clinical trials, but another important step in caring for patients. The other thing I'll touch on now is what impact has research and quality improvement had as we've developed and in multiple facets our GME program, residencies, fellowship. And I see Dr. Brown here and the team and the work that they've done to get this in place. So with the cardiology fellowship, this is one of our classes that I'm showing. We've had a lot of, I think the environment we've created with the research and publications creates an environment that people want to come and be part of, right? So we have young, residents becoming fellows, they're interested, they want to move the needle. This has really put us on a national stage where we're able to compete favorably with some of the best residents nationwide. We have residents here who join us as fellows, whether, Cook County, Emory, University of Florida, UNC, all over, right? So these are folks we've been competitively being able to recruit, whereas they could have easily stayed where they're coming from. But I think research and the quality improvement work we've done has played a big role in that. What are examples of how this has impacted our learners as they've come through? This is a picture of Sharif Dodu. He's one of our fellows who graduated last year. This was at the Georgia ACC local conference, and we won the research award, I think some 2 years ago. As though that wasn't enough, we won it the next year, and we won it again subsequent to that, right? And these are our residence fellows who are going to be part of our system. The other thing I'll mention as we are part of research, when I'm presented with opportunities, so I review for one of our heart failure journals, Journal of Cardiac Failure, I review articles. So when I'm presented with opportunities for reviews, I involve the fellows, and one of the cases we did was with Sharif Dodu when he was here last year. So we were able to publish an editorial where he took the lead and got it together, and this was featured as the editorial of the week during that month. So that was fantastic. All right, we believe so much in research that we actually then created a chief fellowship around quality improvement and research. And that Dr. Riaz Mahmoud took that role, and we'll have him come up shortly to talk more about that. So just to summarize it, with all this that we've done, our fellowship has had 100% match rate in interventional, and thus far we've had 100% board pass rate. I can tell there's a lot of well-established fellowships that have not achieved this in the time they've been doing it, and within 4 years we've been able to do this. Not only has this been noted locally, but also nationally. This was a ACC webinar for fellows and the application process. And because of the novel work we've done and the fellows are really engaged and involved, we're invited to be one of the faculty of this, right? You can see the other institutions that are there. UCLA, Cornell, there's Vandy, there's University of Michigan, and right in the middle, Northeast Georgia Health System. So again, so not only is this work having an impact of the folks we're training, but it's also part of that, creating that network of people recognizing the novelty and the things that we bring to all of this. So that's my take on it. I'm going to invite Dr. Riaz Mahmoud up to speak more briefly and more intently around the topic of how this has impacted his training since he's been here. I think everyone here probably knows Riaz. He's been here almost 8 years now? 7 years. And he was a resident here, probably the second class of internal medicine residency, and stayed on with us as a fellow, did a chief residency year, and has really been a great mentor to a lot of residents, other fellows, and things of that nature. So rather than speaking on their behalf, I'd like for him to give us a few words on this.
Thank you, Dr. Egolum. Thank you, everyone, for being here today. So I'm going to take a couple of minutes just to talk about the resident and fellow perspective and how research has impacted my career here at Northeast Georgia Medical Center for the past almost 7 years that I've been here. So, as you guys, most of you have already experienced NGMC research, GME, research protocols, and they're not the best, but, they're labor intensive, but they're designed for a reason. And so from the very beginning, you're an active participant in research. So oftentimes at other institutions, what you get is a siloed approach. to where the research team is split up into the resident or fellow might do a background or a discussion, and then someone else may do the statistical portion, but no one really fully cohesively understands from start to finish. Fortunately for us, we do get that experience here with the GME research team. So you do start off with a research question that then they help you formulate into a research protocol, which then that translates to how do we get this approved from the IRB? What are the barriers? What are they looking for? And then further data collection. How do we properly collect data? Is this really what we wanted? Or was there something else we were missing? And then we take that data analysis portion with the statistician and then further dissemination of that research. In addition, there's opportunities for committee involvement. So one of the committees that I'm involved in is the Georgia Heart Institute Research and Innovation Committee. This allows me to further understand what sort of research is coming in, what clinical trials are available, and how do we get, as an institution, clinical trials to our institution, just like the ones Dr. Egolum spoke about, and then how do we have competing trials, right? So there may be two trials, which one do we pick and why? Additionally, as you've seen Dr. Egolum showcase all of the different articles that have been published in numerous journals, mainly Journal of American College of Cardiology. So we present all of our research at a global stage, at national, international conferences. And then research here at GME, with GME Research, isn't just case reports, right? As you guys are aware, it helps us research ideas, bridge gaps in care, and then we look at real world outcomes. And then we do it from a collaborative standpoint. We don't just silo again in cardiology. So I've had the opportunities to cross collaborate with folks in surgery, in family medicine, certainly internal medicine, and then as well as nursing, other disciplines as well. And then certainly our quality improvement work helps to improve outcomes. One example that I was involved in when I was an internal medicine resident that I'll give you is not so much cardiology, but I think it's a very good example, is we worked on a project. We looked at our dialysis patients that were undocumented and that would come through the ED for emergent dialysis. Often that dialysis ended up costing a lot to the institution because it also had complications with it, not just the dialysis. So we worked to see how if patients could just come in, and most of you guys now experience that if somebody is undocumented, they just come to the ED and they can sign up for dialysis and leave without having to have a hospital stay attached to it. So that encounter became from an inpatient hospital standpoint where it required a rounding team, all of those things, to just an outpatient sort of visit through the ED. And so how do we accomplish this? We do this from the amazing support that we receive as residents and fellows from the GME research team. So the data that we get, it's high impact data, leveraging EPIC, Cosmos, so you're getting data from other institutions as well through EPIC. And then we're looking at bridging evidence in care, so critically appraising using different methodologies, and then quality improvement. So as Dr. Egolum's talked about a couple of projects, so for example, the amyloid project that I'm working on, so we evaluated how can we better screen patients with amyloid. It's a very detrimental disease when it's missed, and it often goes undiagnosed for years. And so how do we properly and early screen these patients so we can provide better care for them? Mentorship, we have nationally recognized faculty in all different disciplines that are there for us to help us better understand research, better understand quality improvement. And then certainly our analytical depth, the statistical analysis and the way that it's explained to us, it's not just mirrors, here's a p-value, there's a statistical difference. They explain what is the significance behind that p-value, what does it truly mean when you have this difference, and how does this better translate for our patients. And then real-world application and high-impact publications. So we've converted all of these clinical observations, these first things that we've done at our institution, and shared them with others so that they can also perform the same similar interventions for their patients and provide the same high level of care. So I'll share a couple of, presentations that I was involved in my sort of 7 years here. I won't list everything, but, just to highlight a couple. I've been to ACC many times, American College of Physicians, AHA, scientific sessions, multiple others, American Society of Preventive Cardiology. Just for, sake of time, I'll just highlight some of the cardiology ones. But Heart Failure Society of America, National Lipid Association, the Society of Cardiovascular Angiography and Interventions, or SCI, Society of Critical Care Medicine, and then Transcatheter Cardiovascular Therapeutics. All of these are international, globally recognized conferences. In addition, we've had the opportunity to publish in multiple journals, and where I was either a co-author or a primary author, so looking at different manuscripts. So in the Journal of American College of Cardiology, Journal of the Society of Cardiovascular Angiography and Interventions, Journal of Cardiac Failure, and then a whole bunch of other places as well, and then case reports. So, I wanted to kind of also share that this momentum continues forward. So just looking at this past year, looking at from July of 2025 to current year, we've had 36 manuscript publications in cardiology, 47 conference presentations, 11 active projects, and 9 QI projects. So with all of that, how this has impacted me is that it allows me to have a better culture of providing better care for our patients, right? So one is our curiosity for knowledge. So I don't just go and see a patient and then leave. I ask, can we do things better? How do we do things better? As you've heard from Dr. Egolum, information is constantly changing. Medicine is constantly changing. Within the time that you guys have started, new medicines have come out, medications and treatments have changed. I can remember, when I was a medical student, we learned that you treat C. diff with metronidazole. But I can tell you, nobody here would agree with me now, right? Because then we went to vancomycin, fidaxomicin. So just a common example of how things have changed and evolved over time. Similarly, things are growing at a fast pace, so you don't always know if you're doing the right treatment for your patients. So having that mindset of curiosity culture of are we doing the right thing allows us to then go look. Then I've received mentorship here that has been instrumental in helping me grow and network. So I'll give you another example of one of the research projects that I'm involved in is a company out of Europe. They're not approved in the US, but they look at perivascular inflammation. So inflammation around the blood vessels and how that impacts outcomes like heart attacks. So I've, working closely with that company. Again, they're going to launch this. They have an algorithm in the United States, and being able to be one of the first people involved with that company as they're moving into a different landscape for them in the United States, it allows me to then further my career, continue to build on that relationship. And I was only able to do that because we had faculty that brought that trial here and then involved me in it. Additionally, serving on different committees has allowed me to better understand how institutionally we can influence policy to bring clinical trials to our institution and how to better provide that care for patients. And ultimately, all of these things together, as Dr. Egolum pointed out, help us provide better care for our patients. Are we doing the right things? How do we look at our outcomes and improve them? Are we, do we need quality improvement projects? Do we need to do first in human things, interventions, that sort of thing? Thank you.
All right, excellent, thanks. So, having spent a lot of time talking through the sort of the work I've done, and shout out to Dr. Jones for providing me some of these slides. So, want to recognize that we do have a number of my other partners who do just as much excellent work. Dr. Subramanian with his OCEAN study looking at preventing cardiovascular disease. Dr. Ramadan with the Envision study. And when we do studies, we're nationally recognized. We're oftentimes the #1 enrollers, as you can see in some of the studies I've been involved in, that's noted there. So really, there's a whole team, a repertoire that's around us. So how do we get to the future state? I'll quickly touch on what I think are the important key points. So I think leadership alignment, this is critical. I think we're moving towards that angle, with our new CEO, the team that's been built, and things in place. So whether this is the leadership at the GHI level with Haley and Dr. Ahmed, Dr. Jones's leadership of our research department, Shane on the QI side with the GME department. So just getting all our leaders aligned, and I think lots of things are going there. I think having some sort of a physician think tank where, again, I know not everyone's going to be interested in doing this work. Not everyone's going to spend the extra time. But having a core group of physicians who spend their time in this space, coming together, and whether it's an advisory committee or something of that nature, we will be pointing out ideas to each other. The other thing I'll mention is that upfront investment is needed. I know the typical way things cycle is, we put the process in place, there's an ROI, then you make a case for it. But research, I think, is a little bit different. You have to invest upfront, put the resources in, almost overbuild it, so then you can leverage the benefits that comes from it. Additionally, I think we need to create models that reward, encourage, and recognize this sort of work. Unfortunately, we don't have one that's specifically codified as yet, but my understanding is those are some of the conversations that have been had. And then I think we'll see a lot more uptake, get more engagement with our PIs and folks like that. Perhaps we need a dedicated research space. We've got a beautiful cardiac tower. Could we have a research building, right, where all our resources for research, labs, whatever it is all in that space, and people are coexisting and living and thinking through things. Intentional recruitment. I'm not implying that our recruitment is not intentional, but as we recruit new faculty, whether it's internal medicine, cardiology, do we look for individuals who have a knack for doing research and publishing and moving this work forward? I think growing the research throughout our system, a lot of it is Gainesville heavy focus, but our patients in Habersham, our patients in Blairsville, patients in Brazelton, they all deserve access, and perhaps finding ways where we can get that directly to them would be key. Forecasting disruptive technology, right? We talked about the Reprieve system that'll likely revolutionize how we manage heart failure. So identifying what these things are and heavily investing in looking at that. Deploying AI-based technology, right? This is going to be a game changer. We're already using a lot of AI, but the discussion we had around cardiac amyloidosis and how AI could completely change the way we think about and look at that disease process. And then perhaps in the future, really looking at, do we develop an NGHS Research Institute and a Research Center of Excellence, and then doing the things that come with all those in the play. I will say this, the time to do this is now. There's a lot of market forces that are in this research space. I'm not sure if most people are aware, but in Gwinnett County, they're developing their own version of the research triangle, right? So there's, in Decula, they attracted a large pharmaceutical company that's bought land there, and they're going to be building and investing billions of dollars. And the thought here is that, that area is equidistant to Georgia Tech in Atlanta, University of Georgia in Athens, and all the universities that are here. So the idea is to start in creating that ecosystem and attracting research. This is right in our market, so we do need to take advantage of that. There's competitions from other health systems, right? Many of the health systems in the area have started heavily investing in research and GME. They want to push that because they see the upfront aspect of it. A lot of private equity are looking into the space. I've been told by folks in the know that a lot of private equity come, they visit, they look at the area, and this area is seen as a ripe ground for research initiatives and involved in that. Believe it or not, there's a few private research offices that are in this area. If you're traveling around, you may see there's a couple buildings where private individuals set up their own research practice, and they're attracting patients, they're making it profitable, and they're engaged in it. We have a new medical school that's going to be in Athens, right? How do we leverage that to support some of the research work we do? Where do we find alignment in that regard? We don't know what's going to happen tomorrow, right? Right now, there's an advantage for the health system because we have our, restrictions on how many hospitals can be in this area. Who knows? What if 5 years from now, those things change and another hospital can build next door? So we need to take advantage of those opportunities as they currently arise. All right, so this is what I talked about earlier. I will not go into details on it, but hopefully through the things we've discussed, we've clearly demonstrated that this is the impact research has on an organization that's high functioning and has really well-organized service lines. So future directions, I think AI and predictive analytics is gonna be huge. Personalized medicine, how do we provide the right care for the right patient at the right time? real-time clinical decision support. How do we leverage our EMR to make sure we're appropriately taking care of patients at the time we are taking care of them? And then there's this concept of the learning health system, meaning you're not a health system where you stay put and things are figured out and then you turn around and then now you're engaged with it. So we want to be the health system that's at the forefront. We're pushing the envelope, we're helping shape the future of medicine as much as we can. So here are the key takeaways. I think research and quality improvement are the linchpins of any high-functioning system. There's a direct impact on patient outcomes and cost, as we've noted. I think it's essential for leadership and innovation as we build these pipelines. Research and education is part of it. And it's really critical for the future sustainability of any health system moving forward. I'll leave you with this. So again, just to remind folks, this is why I do research. Because again, the idea that I'm taking care of a patient today who may not have a therapeutic option available to them for 10, 15 years. I want my patients to have the best care possible today. So doing research and bringing that to bear is really a big part of it. And I'll quickly remind us of what our mission is, right? Improving the health of our community in all we do. So as we're doing research, quality improvement, this has to be a big part of it. And then this is my closing thought. I believe that we should strive to provide tomorrow's treatment today. Thank you.
Hi, Tiffany Fulford, Compliance Director. What do our demographics look like for those clinical trials, especially in the Gainesville area?
When you say demographics, gender, age?
Age, race, gender.
I would say all the above. It really depends on the specific disease state. So for some diseases that may be more common among African American or Black patients, we may have them predominate, or for disease process more prominent, more women, you may have that. But really, it's opened up to everyone, and folks are recruited accordingly.
Thank you. Second question. For the AI component of the research, is there a validation process to check for accuracy, and what does that look like?
Yes. So with the AI initially, like if you're referencing the one I did with the echocardiography and cardiac amyloidosis, so there will be a mini pilot component of it where we would run it through the echoes that we have and then retrospectively validate that those patients actually did have cardiac amyloidosis. So one starting would be looking at patients we've already diagnosed, run that algorithm and see how many of those patients get picked up, and then looking at a much larger patient population and seeing how that's identified. So that's built into the trial protocol.
Hi, Dr. Egolum. Thanks for a fantastic talk. On that amyloid research project that you're doing with AI, I'm curious because you did say that we're suspecting around 6,000 patients who have amyloidosis but haven't been diagnosed. What is the plan moving forward? I know how busy you all are in clinics. Are these patients just going to be brought in for testing for amyloidosis? Are they going to be called? How are we going to address getting them diagnosed if they do have it?
Yeah, so the plan is once that study gets off and running, we would look at having appropriate staffing around it. So between our nurse practitioners and clinic, if there are fellows who want to be involved, we would create this panel and folks would have access to it to review. And then the plan there will be proactively reaching out to the patient, with the support of their PCP and their general cardiologist. So that would be the plan once that's done. Thanks for that question.
That was an amazing presentation, very exciting stuff.
Thanks.
My quick question for my interest is the FASTER-2 trial, I think, the device. Are there any plans to expand the use of that device, whether it's an infusion center or a tower? How many are actually active right now?
Yeah, so this is still part of a clinical trial protocol, so not yet commercialized. We've enrolled patients here, and other centers have done the same. I've talked briefly with the team that's sponsoring the study, and we've had ideas of other ways this can be implemented, whether even in our clinic setting, in the ER, for example, right? So these patients who have heart failure don't necessarily have to be admitted to the hospital. You can get a volume off and they go home from the ER. But right now, the clinical trial is focused on what happens when they're in the hospital. And that's where we've seen really fantastic results. I mean, again, like I mentioned earlier, patients now spend an average of 5 to 7 days in the hospital. With this device, we can get them out of the hospital within 24 hours. So that's going to be a really major upside for the health system in terms of saving costs and providing that technology. Thanks.